Hello, my name is Ben Ayers and I'm a consultant urologist at St George's Hospital in London. Thank you for asking me to talk to you today about how we manage lymph nodes in penile cancer. I know my colleague Nick Watkin had been asked to do this and he sends his apologies as he's very ill at the moment with a bad case of tonsillitis, but he sends you all his best wishes. Just to set the scene, at St George's Hospital in London, our referral base for penile cancer is about 12 million of the UK population. It's because hospitals from across the south coast and up into Essex refer to us. That means we see about 100 new cases of penile cancer a year. Just to set the scene as why I feel that lymph node management is so important, we have noticed since centralisation in our region, and that occurred in about 2001, that the 5-year survival for penile cancer has improved from 75% to 85%. And we feel that that is down to better pathological staging and then subsequent management of patients' inguinal nodes. And this is primarily due to the introduction of inguinal sentinel lymph node sampling, and I'll be talking to you about this later on in this clip. At the end of my talk, there'll be a few slides summarising the points that I've made. So first of all, why is managing inguinal lymph nodes so important, or understanding inguinal lymph nodes so important? It's because they're the strongest prognostic indicator of survival, of cancer-specific survival in penile cancer. Cancer-specific survival is also determinant on the number of nodes involved and also on whether or not there is extracapsular spread in the node. We have combined some of our data with that of Simon Horenbla's group in Amsterdam. We did this a few years ago, and it gave us a grand total of 1,000 patients. And we found that those that were negative in the groin or had one positive node in the groin without extracapsular spread, i.e. PN1 disease, had a similar 5-year cancer-specific survival approaching 100%. It was in the high 90s. Patients with PN2 disease, that is, 2 or more inguinal nodes without extracapsular spread, they had an 80% 5-year survival. And those with PN3 disease, that is either extracapsular spread in the groin, whether it's one or more nodes, and or pelvic lymph node involvement, their 5-year cancer-specific survival was around 30%. So as you can see, the involvement of lymph nodes is very important in predicting survival. The other important message I would like to get across is that we treat each groin on its own merits. So just because a patient has a nasty penile cancer does not necessarily mean that the groins are involved. Sometimes some of our worst inguinal nodal involvement is when the penile cancer is a tiny little thing on the foreskin. But also, if one groin is bad, it doesn't necessarily mean the other groin and or pelvis is bad. So we treat each groin on its own merits, and if that groin is involved, we then treat that groin. But if that groin is not involved, then we do not do extensive more surgery or treatment on it, because that carries significant side effects of treatment without any benefit in our experience. So if a patient presents with a positive node in the groin, well, their management is fairly straightforward, and about 30% of patients present to us in this way. And if we feel a palpable node in the groin, more than 85% of them are involved with cancer. I know historically there was a study that used to say about only 50% were, but that is not our experience. In our experience, and I think the experience of other big centres in Western Europe and America, it's over 85%. If we feel a palpable node in the groin, With penile cancer, then we get a fine needle aspiration or core biopsy of it to prove the diagnosis. If it is involved, then we get a staging CT scan or MRI scan. We use a CT scan of the chest, abdomen and pelvis at St George's Hospital. And then following that, we will then go on, obviously treat the primary cancer, but we will then go on and do a full inguinal lymph node dissection on the side that is involved. Now that involves taking all the fatty tissue with all the lymph nodes in it from the groin, and it's a template dissection where we go above the inguinal ligament, just above the inguinal ligament, start taking the fatty tissue from there and go all the way down onto Hunter's Canal and just beyond Hunter's Canal. Laterally we go out to the tensor fascia lata, and medially we go all the way to the adductor muscle. So we have a big template of the groin where we take all the fatty and nodal tissue away. Now that unfortunately does carry quite high morbidity. There is a high rate of wound infection. In historical texts there has been a high rate of wound breakdown and necrosis, but luckily, again, that is not our experience at St George's Hospital. We use a supra-inguinal incision, and we do careful dissection of our skin flaps and do not experience it that often. These men often suffer paresthesiae in the inner thigh because the nerve is involved with that fatty tissue, and despite best attempts to try and preserve as many nerve fibres as possible, they still experience some paresthesiae in the groin. And the other complication is lymphedema, which ranges. Some people have none or very mild, to others where it's significant, and it can affect the lower limb and the genitals. Some men, but again quite rarely, get recurrent attacks of cellulitis and have to go on prophylactic antibiotics because they get quite sick with that cellulitis. But the big problem really is the lymphedema and the wound infections, and this operation carries about a 40% chance of complication with it. That then causes a problem when you have a clinically node negative groin, i.e. you cannot feel any palpable nodes in the groin at all, and this occurs in about 60 to 70% of the patients that present to our service. And we know that only about 20% of these patients with clinically node negative groins will have micrometastatic disease in their groins. There's no way of seeing that micrometastatic disease. Ultrasound, CT scan, PET CT scan are not sensitive enough to pick them up. And if we did an inguinal lymph node dissection on all these patients, there'd be huge morbidity. So it's a very difficult group of patients potentially to manage. We do know, however, that if there is a survival benefit of picking up the disease in a micrometastatic disease rather than observing them and treating when a lymph node appears. And we know that survival benefit is somewhere in the order of 85% 5-year survival compared to 35% 5-year survival if you observe and wait for a lymph node to develop if one were going to develop. So again, we want to treat these patients in the micrometastatic stage. Risk-adapted nomograms have been talked about. We know that grade 1 disease to grade 1 TA or grade 1 T1 disease has a very low risk of metastasis, somewhere in the order of 1 to 2%, and therefore generally these patients would not be offered lymph node dissections. G2 T1 disease has about a 12% risk of finding micrometastatic disease, whereas G3 T1 and above, it's somewhere in the order of 15 to 35%. So if you use a risk-adapted nomogram, you would be recommending lymphadenectomy in at least these high-risk patients, possibly even the G2 T1s as well. And if you offer a high-risk, the high-risk group lymphadenectomy, about 3/4 of them would have a bilateral lymph node dissection that was negative. So again, there's still huge amount of over-treatment and over-morbidity due to this treatment in this nomogram approach. At St George's Hospital, Nick Watkin developed inguinal sentinel lymph node sampling soon after Simon Horenblast had introduced it in Amsterdam. And we believe this has made a big difference to our practice and how we manage to stage pretty much all of our patients accurately with pathological inguinal nodal staging, which then determines appropriate management. So the sentinel lymph node concept is that the cancer will drain to the sentinel node, i.e. the first node that drains the penis. This is similar to the concept in melanoma and breast cancer. So it will drain to the first lymph node, and sometimes there's a couple of tracts, so sometimes there's one or two or three sentinel nodes. And if that node is involved with cancer, then there is a risk that other nodes are involved in cancer. And in our experience, about if a patient has positive sentinel nodes, then they have about a 20% risk of having additional nodes elsewhere in the inguinal chain. The concept falls apart if a lymph node is so stuffed full of cancer that the lymphatics have started to bypass it. And therefore, the sentinel node that you identify on radiological imaging is not the true sentinel node. And that's because the tracer has missed the sentinel node because the lymphatic drainage has changed because that node is full of cancer. And therefore, there is a small risk of false negative results, and that happens in this situation. And to prevent that, or to reduce that risk as much as possible, we do an ultrasound scan on the day, and if any abnormal nodes are seen on the ultrasound scan, then they have a fine needle aspiration, which is our safety net in case there is a node that is full of tumour and might potentially be missed on the sentinel node biopsy. Also, as a point of technique, do it when you do the sentinel lymph node biopsy. If you feel a very large or abnormal node, then again, I would remove that and send that for pathology, even if it wasn't radioactive, because I would be suspicious that it might be a node involved. So when patients have sentinel lymph node sampling at St George's Hospital, they spend the morning of the day of surgery in the radiology department. They have some little injections in the mid shaft of the penis of a radioactive colloid, nanocolloid, that then goes through the lymphatics to the sentinel node, and this is then identified on a gamma camera, and the images are there for us in theatre. Then when they come up to theatre, we inject some patent blue dye again into the shaft of the penis, just very subcutaneously, so that we can that will then travel through the lymphatics and turn the lymph nodes blue that are the sentinel nodes. So again, we have a visual clue, and we also have a gamma camera in theatre that allows us to pick up the sentinel nodes. We can then do a small incision on each side and take the one or two sentinel nodes out and leave the rest of the nodes in place. Patients do suffer sometimes with some temporary lymphedema, but it is temporary, and there's a small risk of a hematoma and infection. And our overall complication rate on our series so far is 7.6%, and that's on a 365 patients when this was last looked at. Our pickup rate on those 365 patients, and they have at least 3 years follow-up, is that 20% of the patients had positive nodes with micrometastatic disease, and there were 6 false negative studies. So we believe that sentinel lymph node sampling has changed how we manage penile cancer, because it allows us to accurately pathologically stage our patients' inguinal nodes with much lower morbidity than a full inguinal lymph node dissection, and allows us to pick up that micrometastatic disease early, when we can then offer additional treatment that could improve survival. And we believe this is partly, if not mainly the reason for the improvement of our 5-year survival from pre to post centralisation, although obviously that was an observational study and there's no direct evidence to prove that. The last thing that I want to talk to you about is pelvic lymph nodes. Now, there is a controversy about how pelvic lymph nodes should be managed because we do not know whether surgically removing them adds any survival benefit to the treatment. Historically, the survival benefit with pelvic lymph nodes involved with disease has been extremely poor, in the order of 25 to 30% 5-year survival. They can be treated with chemoradiotherapy, and that's why there's these questions over whether we should be putting these patients through surgery as well. There's a big international trial about to start called the IMPACT study, which is randomizing patients to surgery followed by chemoradiotherapy to chemoradiotherapy alone. So hopefully this question might be answered. The trial is also going to be looking at inguinal lymph node management and whether neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy is beneficial there as well. Our experience of pelvic lymph node dissection at St George's Hospital has changed over the last few years. We started to do them minimally invasively using the Da Vinci robot, and what we found is that means that we can offer pretty much every patient who has the indications for a pelvic lymph node dissection the option of having a pelvic lymph node dissection, because the minimally invasive nature of that surgery means that they get through the surgery very well and are discharged home the next day. I would like to point out there is a risk of deep vein thrombosis and pulmonary embolism with this type of surgery, and despite using extended prophylaxis of low molecular weight heparin for 28 days after the surgery and encouraging them to mobilize, there is still around a 10% risk of DVT or PE. So that's something that does need to be borne in mind. And the risk of treating the pelvic nodes is that there's increasing lymphedema as well, which is a problem. So the EAU guidelines suggest that pelvic lymph node dissection should be considered in patients with 2 or more positive inguinal nodes. We do a template dissection similar to what you might do in bladder cancer. We take all the iliac and obturator nodes from the sort of pubic bone up to where the ureter crosses the common iliac artery, and we go out laterally as far as the genitofemoral nerve, and medially we come into the medial umbilical ligament, and we take it out as one packet. Now, since 2012, January 2012, we have had 31 men who have been have had extracapsular spread in the groin, and so sorry, I said earlier on that the EAU guidelines suggest that you should do pelvic lymph node dissections if somebody has 2 or more positive nodes in the groin. They also recommend that you should do them if you have extracapsular spread in the groin. So we have 31 men who have had extracapsular spread in the groin who have had negative pelvic nodes on CT scan. So we're looking for micrometastatic disease. So some case selection here. But we've found that with this cohort of patients, and 94% of them had robotic lymph node dissection, and 82% of them went on to receive adjuvant chemoradiotherapy, so these have had a lot of treatment. We found that 52% had micrometastatic disease in at least one pelvic node in the ipsilateral groin to where the inguinal node was involved. So 52% have micrometastatic disease in at least one ipsilateral pelvic node. And we found that the 3-year overall survival is very, very similar between those that were pelvic node positive and those that were pelvic node negative in this high-risk cohort of patients who have PN3 disease and extracapsular spread in the groin. So we found that 3-year overall survival was 65% in the those that have micrometastatic disease in the pelvis compared to 69% in those that had no micrometastatic disease in the pelvis. Now, I cannot say that the surgery has made a difference in terms of the survival here by removing the nodes that we're effectively treating them, because these patients have gone on and had chemoradiotherapy as well. But what I would like to suggest to you is that by you doing full pathological staging again, just as we do full pathological staging using our Sentinel nodes, by doing full pathological staging, we have picked up micrometastatic disease in quite a large number of these patients, 52%. I mean, historically, if you look in the literature, people quote maybe about a 30% pickup. So we've picked it up in many more patients than historically people were reporting, and perhaps this, with the surgical treatment and the chemoradiotherapy treatment, so this has led to fuller treatment of these patients, has offered a survival benefit. Well, thank you for allowing me to talk to you on this topic. I'm sorry it's been pre-recorded and so there's no ability to do questions and answers, but perhaps that's something that could be facilitated in the future, and I'd be very happy to web link in with you in the future and try and do a question and answer session if possible. And now follow a few slides just summarising the points I have made. Bye-bye.